and welcome you to our first training since the PHE was declared in 2020. I'm Carol Eastberg, the Nevada State REI Coordinator with the Division of Public and Behavioral Health, Bureau of Healthcare Quality and Compliance. I've been with the Bureau going on 17 years now, and this will be my 9th year as the REI Coordinator. Prior to this, I participated in on-site inspections and complaint investigations for the various facility types, including long-term care for 7 years. The Bureau is actually the state survey agency. We work as an arm of the feds to ensure that the regulations are being followed and that the residents are receiving the care that they need. Prior to that, I did home health, so that's a little bit of my background. Before we get started, a few housekeeping notes and preliminary remarks. Please do not use the chat feature except to let us know if you are having technological issues. So if you can't see or hear the presentation, please put that in the chat. Otherwise, nobody should be using the chat. We want all eyes on the screens and your ears attuned to what we are saying. No breaks are scheduled, so if you need to step away from your computer for any reason, please hurry back. We will have a Q&A after each one of us presents. So if you have a question during that presentation, please wait until the presenter is finished, as they may answer it. And if not, make yourself a note and we will be glad to take your question during the Q&A. I would caution you to please, when you ask a question, stay on topic, whatever has just been presented, and please don't go into storytelling or one-upmanship mode. Please keep yourself on mute until called upon. And if you have a question, you can click on the raise hand icon and wait for one of us to acknowledge you and let you speak. We would really appreciate your grace and patience today. This is my first time actually presenting on the Teams platform, and it's also the first time that Chris Cristiano, the Medicaid Case Mix Coordinator, and I are collaborating to present these topics in this ever-changing world of long-term care facilities. As I mentioned, no breaks are planned today, and due to the amount of information we have to present, we may not get through it all today, but not to worry. We plan to host these trainings every other month, so wherever we end today, we'll pick it up from there the next time we meet. All right, the objectives for this particular session are shown on slide 4, and I won't insult your intelligence by reading them to you. There are 3 main objectives. And I just realized, well, hold on, I'll get to that. All right, next, a disclaimer. This training is meant to provide an overview of recent and forthcoming changes which affect long-term care facilities as required by regulations and overseen by the Centers for Medicare and Medicaid Services. Excuse me. CMS has not provided state REI coordinators with any training regarding recent and the upcoming changes. Content for this presentation was gathered from information available on various websites, in newsletters and other publications to which I subscribe, which I also forward to you all when there is news that you can use. On March 24th, I sent out a poll to all MDSCs on my email distribution list with the question shown here. By the way, thank you to the 22 people out of over 120 who responded, even the magnificent 7 who only responded with the date and time preferences. The 15 numerical responses that I did receive to question number 1, which on a scale of 1 to 10, with 1 being not and 10 being totally comfortable, how comfortable you are with the current item sets averaged to 7, which is not too bad. It's closer to a 10 than a 1. The most frequently listed sections of the RAI that respondents found frustrating were G and GG, care area assessments, and then The third most frustrating section was a three-way tie between sections I, Q, and care planning. During this presentation, I will attempt to address as many topics from the poll results as possible. And I also want to mention that responses to the third question were very general. For example, RAI or section D. So there were also a lot of blanks, as I mentioned earlier. So we're going to get started. And if I don't respond to your poll questions, you can shoot me an email and ask me, what about this or however, and we can cover it on our next presentation. And with that, let's get started. For those of you who are newer in their position as nurse assessment coordinator, and I know we have a couple, I found that out from the poll, or MDS nurse assessment coordinator, as they're also called, as well as a refresher for the rest of the group, we tend to lump all the parts of this into what we call the MDS. But the MDS is actually one of three equally important components, which when combined are technically called the RAI instrument, or Resident Assessment Instrument, or RAI. The other components include the Care Area Assessment, also known as the CAW, and the User Manual. Excuse me. Nurse assessment coordinators, as well as all members of the interdisciplinary team, or IDT, should read the manual, especially Chapter 3, to become familiar with and understand the entire process. Excuse me. Chapter 3 is the overview of the item-by-item guide and is basically the Bible for the whole process. The MDS elements, also known as items, provide an efficient, standardized, and systematic screening method to capture the baseline snapshot of a resident's overall status. A while back, I was presenting regarding the Impact Act and how all of the elements were going to be standardized in all post-acute care settings. Long-term care has not had to adjust that much, but I can tell you that home health agencies have a whole new set of standardized items that will now correspond to what's being collected in long-term care. So that's a good change. The IDT uses the data to help each resident plan for their unique physical, behavioral, emotional, social, and spiritual care needs, as well as to set goals. Federal regulations require the RAI process must be completed for each resident at various times throughout their stay. Assessments drive the CAW and care planning processes. And due to the ripple effect, an inaccurate assessment puts the resident at great risk. In addition, state surveyors review the MDS for accuracy, frequency, and timing, as well as other documentation to assess the facility's compliance with federal regulations. And just so you know, if assessments are determined to be inaccurate, your facility could be cited for a deficiency at tag F641. The CAW process helps the IDT drill down to determine which issues require care planning to keep the resident safe and meet each of their various but specific needs. I'm planning to go into the CAW process a little bit later, but that might end up being in our next session. Whether you call it by its full name or one of the alternatives listed here, the manual provides detailed instructions for each item in the RAI, along with how to determine the appropriate code for them. It includes instructions for completion of the RAI, as well as structured frameworks for integrating MDS and other clinical information needed by the nurse assessment coordinator. There are also many examples sprinkled throughout describing different scenarios and how they should be coded. On a side note, back in 2017, the manual was only 1,393 pages in length. The draft manual in the works for the changes coming on October 1 this year is currently at 1,694 pages. All right, let's get into Section A. Section A of the Comprehensive Nursing Assessment collects all the basic information, including your provider ID, which is also known as your CCN. It starts with 29. The provider type, which is either a skilled nursing facility or nursing facility or swing bed. The type of assessment being conducted, certification status of the provider, and so on. Here, I just want to caution you to always enter the resident's name exactly as shown on their Social Security or Medicare beneficiary card, including the middle initial or a suffix if they have one. You need to ensure that the middle initial is entered in the designated field A0500B and not in the first name field A0500A. If they have a suffix, you need to be sure to enter it consistently. And please double check spelling. I have to tell you, I get many emails asking me to help facilities get the residents' names off of the roster because they're no longer in the building. And so the reason for that is usually a different name was provided, or it was spelled incorrectly, or the middle initial was inserted there in AL500. So just keep that in mind. And also, I recently had a situation where the business office changed the last 4 digits of the Social Security number, which really messed things up. I think we got it straightened out. Item B0100 asks if the resident is in a persistent vegetative state or no discernible level of consciousness. If the answer to this is no, the clinician enters a 0 in the box. If the answer is yes, the current instructions are for the clinician to enter the number 1 in that enter code box and then skip to section G110, activities of daily living assistance. Beginning on 10/1/23, if the response to B0100 is yes, you will skip to section GG, higher functional abilities and goals. The rest of section B assesses the resident's ability to hear, communicate via speech or sign language or communication board or whatever method they use, understand others, and to see. When conducting this assessment, the resident should be assessed using any type of aid that they normally use to see. So for that, it would be glasses, or if they have a specialized vision aid, they should have that to use, or any other kind of communication board, an interpreter. And if they do need an interpreter and a family member is not available, the facility needs to provide an interpreter, which can be accessed. There are telephone services that provide that. And I also want to point out on this slide that the look back period for all items is 7 days unless another time frame is indicated. Section C documents the resident's cognition status and should be attempted for each resident. This would include residents on ventilators if they're awake and alert. Obviously, they're probably going to have a different method of communicating back, but their cognition should definitely be assessed. And the instructions are very specific, so be sure to read and ensure that you understand this vital portion of the assessment. If the resident is rarely or never understood, the instructions are to skip over to and complete C0700 through Z1000 staff assessment for mental status. Section D documents the resident's mood. D0100 asks if the resident can be understood, which you would have just previously documented at C0100. So if the resident is able to understand the questions and respond appropriately and be understood when responding, then you would go ahead and conduct the interview. Notice that the current version indicates if you code D0100A1 as a yes, you are to continue to D0200 for the resident mood interview, also known as the PHQ-9. Effective 10/1/23, you will do an abbreviated interview of just the first two questions, which is called the PHQ-2. If the resident responds no and never to both questions, the rest of the PHQ does not need to be completed. You can go ahead and move on to D0160 to enter the total severity score. If the resident answers yes for either question of the PHQ-2, you must ask the remaining 7 questions of the PHQ-9. Just like in section C, if the resident is unable to be interviewed, you would code D0100 with the 0 for no, and skip to and complete D0500 through D0600 staff assessment of resident mood. In section E, the resident's behavioral symptoms observed over the last 7 days are documented. For item E0100, if the resident had hallucinations or delusions over the last 7 days, code by checking the appropriate box. This is one of the rare instances where you're just checking a box. Most of the boxes require you to actually enter a code. If they had neither hallucinations nor delusions, you would check the box next to Z for none of the above. If severe, both hallucinations and delusions can cause harm. So, of course, if either one is identified, prompt follow-up and care plan interventions must be carried out. And remember, the focus is on the resident's actions, not the intent of their behavior. Keep in mind, the instructions are to code the behaviors and/or thoughts expressed in the last 7 days, and not the presence of a medical diagnosis. The resident should be observed in a variety of situations during the 7-day look-back period. All disciplines from all shifts, as well as anyone else who had close interactions with the resident, and this would include family or friends or the hairdresser, housekeeping. If there was an incident, they should be reporting that. So everyone should be interviewed who had an interaction where the resident was having either hallucinations or delusions that affected them, right? Hopefully that makes sense. Item E0200 requires you to code the frequency of the 3 specific types of behaviors. If the behaviors listed in E0200A were not exhibited at all, you would enter a 0 in the box next to A, and the same for B and C as applicable. But if the behaviors described in either A, B, and/or C did occur, you will need to determine exactly the number of days during the last, how many? 7 days, unless otherwise indicated. In this case, it's 7 days. Okay, and you would code that in the corresponding boxes A, B, and C as appropriate. Item E0300 asks if any behavioral symptom questions in E0200 were coded a 1, 2, or 3. If the response is no, there were 0, or 0 for no, You would skip E0500 and 0600 and go on over to E0800, rejection of care. For a yes response, which is a 1, items E0500A, B, and C will need to be coded. So E0500A asks if any of the identified symptoms put the resident at significant risk for physical illness or injury. Code 1, yes, if any of the identified behavioral symptoms place the resident at clinically significant risk for physical illness or injury, even if no injury occurred. So in other words, did they put themselves at risk, even if no injury occurred? So if their behaviors were so outlandish that they could have hurt themselves or caused themselves to become ill, physically ill, then you would code that as a 1, yes. E0500B asks if any of the identified symptoms significantly interfered with the resident's care. Well, there again, you'd code 1, yes, if any of the identified behavioral symptoms impeded the delivery of essential medical care, nursing, rehabilitative, or personal care. And this includes, but is not limited to, assistance with activities of daily living, such as bathing, dressing, feeding, or toileting, that is required for the resident to achieve their goals for health and well-being. And if it cannot be provided safely, completely, or in a timely way without more than a minimal accommodation, such as a simple change in care routines or environment. E0500C asks if any of the identified symptoms significantly interfere with the resident's participation in activities or social interactions. You would code this item 1, yes, if any of the identified behavioral symptoms significantly interfered with or decreased the resident's participation or caused staff not to include residents in activities or social interactions. So that would be to the extent that the resident's behavior is limiting or keeping them from engaging in solitary activities or hobbies, joining groups or attending programmed activities, or going on outings or having positive social interactions with visitors, other residents, and or staff. When staff attempt to change her soil brief, a resident frequently scratches and grabs them, digging her nails into their skin, making it very difficult to complete the care task. In this case, E0500B would be coded 1 for yes, because this behavior did interfere with delivery of essential personal care. I'll just add here that it might also be a good idea to care plan for and keep her nails very short. By the way, since we do have a limited amount of time today and a lot of information to cover, I'm not going to present any additional examples. Instead, I will give you the page numbers where you can find them in the manual. So behavioral examples begin on page E11 of the current manual. E0600 is a 3-part item addressing the impact of a resident's behaviors on others. E0600A asks if any of the identified symptoms put others at risk, at significant risk for physical injury. And remember, this includes other residents, staff, and visitors across all shifts. Code 1 for yes, if any of the residents' identified behavioral symptoms placed staff, visitors, or other residents at significant risk for physical injury. E0600B asks if the residents' identified behavioral symptoms kept other residents from enjoying privacy or engaging in informal activities that was not organized or run by staff. This includes going into another resident's room uninvited, invading or forcing oneself on others' private activities. Maybe a card game is going on and the resident walks up and tries to, whatever, interrupts it with their behavioral symptom. And then last on this slide, E0600C asks, oh no, that's not last on this slide, sorry. Asked if any of the identified symptoms significantly disrupted care or the living environment. You'll be coding 1 for yes if any of the identified behavioral symptoms created a climate of excessive noise or interfered with the receipt of care or participation in organized activities by other residents. And finally, E0800 asks if the resident rejected an evaluation or provision of care, such as lab work, medications, assistance with ADLs, which is necessary to achieve the resident's goal for health and well-being. Code 0, behavior not exhibited, if rejection of care consistent with the goals was not exhibited in the last 7 days. Code 1 for behavior of this type did occur between 1 and 3 days. If the resident rejected care consistent with goals during 1 to 3 days of the 7-day look-back period, regardless of the number of episodes that occurred on any one of those days. So you're just coding the number of days that any of the behavioral symptoms were exhibited. Moving on to the next one is you're going to code, we're still talking about rejection of care. So if the behavior of this type occurred between 4 and 6 days, but less than daily during the look back period, you would code a 2. I think it's pretty self-explanatory. So then, of course, you would code 3 if the behavior of this type occurred daily during the 7-day look back period. And that is regardless of the number of episodes. So maybe it happened once a day for 7 days in a row, or maybe it happened 3 days on one day, one time on the next day. It was multiple occurrences throughout the 7 days. As long as it happened daily, at least once daily, you would code a 3 in E0800. Hopefully that made sense. E0900 asks if the resident wanders, and if so, how often? Well, first we should consider what is wandering. It is the act of moving, walking, or locomotion in a wheelchair from place to place with or without a specified course or known direction. Wandering may or may not be aimless. The wandering resident may be oblivious to his or her physical or safety needs. The resident may have a purpose, such as searching to find something, but he or she persists without knowing the exact direction or location of the object, person, or place. The behavior may or may not be driven by confused thoughts or delusional ideas. For example, when a resident believes she must find her mother, whom staff know is deceased. If wandering behavior was not exhibited during the 7-day look-back period, code 0, behavior not exhibited, and skip over to E1100, change in behavioral or other symptoms. If behavior of this type did occur between 1 and 3 days, code a 1. If the resident wandered between 1 and 3 days during the 7-day look-back period, regardless of the number of times it occurred on any one of those days. And then proceed to answer wandering impact item E1000. Code 2, behavior of this type occurred 4 to 6 days, but less than daily, if the resident wandered between 4 to 6 days during that 7-day look-back period, regardless of the number of episodes. You would code 3, behavior of this type occurred daily. If it happened at least once a day during the 7-day look-back period, you would code a 3. Pacing, which is repetitive walking with a driven pressured quality within a constrained space, is not included in wandering. So pacing is not included in wandering. Traveling a planned route to another specific place, such as going to the dining room or to an activity, is not considered wandering. And wandering may occur even if the resident is in a locked unit. E1000 A and B should only be coded if E0900 was coded a 1 for the behavior of this type occurred 1 to 3 days, if it was coded a 2 for 4 to 6 days, or a 3, behavior of this type occurred daily. E1100, the last item in section E, requires consideration of all the symptoms you just assessed in items E0100 through E1000 to determine if the resident's behaviors have stayed the same, improved, or worsened compared to the most recent prior assessment. If this is the resident's first assessment, you would select 3, NA, because there was no prior MDS assessment with which to compare the status. The examples for this can be found on page E22. Okay, that brings us to section F, preferences for customary routines and activities. F0300 asks if an interview for daily and activity preferences should be conducted. And the authority on this topic would be who? The resident, right? But if they can't be interviewed for whatever reason, you would need to speak with a family member, a friend, or advocate if they have one. If they have none, you'll need to skip over to and complete F0800, staff assessment of daily and activity preferences. Notice the manual includes the statement that nursing homes should use this as a guide to create an individual plan based on the resident's preferences and is not meant to be all-inclusive. In light of that statement, when you reach the end of section F, you might want to say to the resident, is there anything else we should know about your daily routines or activities before you came here? For both section 0400 and 0500, I'm sorry, zero. The instructions are to show the resident the response options, but what if they have visual limitations? We'll get to that in a minute. If their vision is intact, you can show the options while verbally explaining it to the resident and or their advocate. The options for which the responses are shown on the left-hand side under coding. It was also suggested that you could make an index card with the options, 1 very important, 2 somewhat important, etc., to show them, because you could make it in a larger font so that they can be sure to see it. You need to be sure to read the instructions beginning at the bottom of page F3, F as in Frank, 3, in the manual for suggestions on steps to take for a successful interview. The manual points out that sometimes respondents give long or indirect answers to interview items. So to narrow the answer to the response choices available, it can be useful to summarize their longer answer and then ask them again which response option best applies. This is known as echoing. For these questions, it is appropriate to explore the resident's answers and try to understand the reason. In other words, you don't just ask them once and try to glean from what they tell you what you think the right answer is. Make it a conversation where you actually echo back to them. You understand what they said, but then you need a little more clarification to their response so that you can code this accurately. This interview is considered incomplete if the resident gives nonsensical responses or fails to respond to 3 or more of the 16 total items in F0400 through F0500. If the interview is stopped because it is considered incomplete, fill the remaining F0400 and F0500 items with a 9 and proceed to F0600, daily activity preferences, primary responded. While facilities are required to complete this interview within the 7-day look-back period, there is no look-back period defined for the resident to indicate preferences. So maybe 6 months ago, they were totally independent and all of these, these questions didn't matter. They were able to do it. But now, a week ago, they're not able to. So the questions are, how important is it to be able to do these things? Be sure to see the examples for F0400 on page F as in Frank 6 of the manual. When coding F0500A, be sure to include Braille and or audio recorded material if that's how they are able to read or listen to the news or whatever they like to do, music they like to listen to. Other than that, the approach, the interview tips, and the techniques are the same as for the F0400 items. F0600 establishes the source of the information regarding the resident's preferences. You would code as appropriate, entering a 1 if the resident provided the information, or 2 if family or significant other responded, or a 9, interview could not be completed, and that would mean no response to 3 or more items was captured. F0700 is where you will indicate if a staff assessment of daily and activity preferences should be conducted. You can read the 2 available responses and determine which one is appropriate. If the response for F0700 is 0 for no, skip over to and complete section G, functional status. See steps for assessment beginning at the bottom of F14 in the manual. F0800 provides an alternate means of assessing daily preferences for residents who are unable to be interviewed. F0800 is to be completed only if F0400 and F0500 were not completed because the resident, family, or significant other was unable to answer 3 or more items in the combined sections. So if 3 or more items were coded as 9, no response or non-responsive, or with a dash because it's unknown, then the interview was not able to be completed. If F0400 and F0500 were not completed, F0800 should be completed based on input from all disciplines, from all shifts during the 7-day look-back period. And now for section G, functional status. As you may or may not have heard, as of October 1, 2023, section G will no longer be included in the MDS 3.0. My understanding is that several items from section G will be revised and incorporated into section GG. And Chris will be going over section GG during his presentation. Until 10.1, you will continue coding the resident's ability to self-perform activities of daily living in the current section G according to the rule of 3. If a resident is unable to carry out ADLs independently, you will code the amount of support required using the rule of 3 located at the beginning of section G and also shown on this slide. And there are tools out to help you if you're new at this and just want additional information. Be sure to code section G with the resident's actual observed functional ability and not what you think or believe the resident should be able to do. It needs to be what all of the different disciplines actually observe, and then of course document to be transferred into this assessment. Your nursing assistants must be adequately trained on how to document the resident's level of self-performance and the amount of support required on the flow sheets, since that data for these sections will be collected from those sheets. In this section, I-0200, the category of the resident's primary active diagnosis is coded. In other words, what is the main reason for the resident being admitted for this Medicare Part A skilled stay? There are 13 categories from which to choose, and you'll need to indicate the resident's primary medical condition category of active diagnoses in the last 7 days. So you can see that if you entered 01, the resident would have had a primary medical condition due to stroke. And examples of that include ischemic stroke, subarachnoid hemorrhage, cerebral vascular accident or CVA, and other cerebral vascular disease. Code 02, if the resident's primary medical condition is of the category of non-traumatic brain dysfunction, which would be Alzheimer's disease, dementia with or without behavioral disturbance, malignant neoplasm of the brain, and anoxic brain damage. Code 03, traumatic brain dysfunction, if the resident has a traumatic brain injury, severe concussion, or cerebral laceration and contusion, which causes them to have traumatic brain dysfunction. You would code 04 for non-traumatic spinal cord dysfunction if their medical condition category is a non-traumatic spinal cord injury. This would include spondylosis with myelopathy, transverse myelitis, spinal cord lesion due to spinal stenosis, and spinal cord lesion due to the dissection of the aorta. Code 05 if they had a traumatic spinal cord dysfunction. So if it's due to paraplegia or quadriplegia following a trauma, automobile accident or gunshot wound would be examples that would cause that. Code 06 if they have a progressive neurological condition, such as multiple sclerosis, Parkinson's disease. I can't think of the other one, but it's not listed here. Code 07, other neurological conditions. So if the resident has cerebral palsy, polyneuropathy, and myasthenia gravis, those would be coded under 07. If their primary medical condition is an amputation, you would code 08, which is an acquired absence of limb. Code 09 for hip and knee replacement, if they just had a total knee replacement or a hip replacement. If a hip replacement is secondary to a hip fracture, you would code that as fracture, 10. And then code 10, 10, fractures and other multiple traumas, such as a hip fracture, pelvic fracture, fracture of the tibia and fibula. Then you would code 11 for other orthopedic conditions, such as unspecified disorders of the joint. I believe arthritis is in that one. Code 12, debility, cardiorespiratory conditions, if the resident's primary medical condition is a debility or a cardiorespiratory condition. which would include chronic obstructive pulmonary disease, COPD, asthma, and other malaise and fatigue caused by cardiopulmonary conditions. Code 13, medically complex conditions, if they have multiple medically complex conditions such as diabetes, pneumonia, chronic kidney disease, open wounds, a pressure ulcer or injury, infection, and disorders of fluid, electrolyte, and/or acid-base balance. The examples for this section begin on page I3 of the manual. The next area of section I is where you will document additional diagnoses currently affecting the resident. The first step is to identify diagnoses. The disease conditions in this section require a physician-documented diagnosis or a non-physician practitioner, NPP, as allowable under state licensure laws, which Nevada does allow. And that needs to be within the last 60 days. So within the last 60 days, a diagnosis needs to have been documented as active by either a physician or a non-physician practitioner. Medical record sources for physician diagnoses include progress notes, the most current recent history and physical, transfer documents from another care facility, discharge summaries from another care facility, a diagnosis/problem list, and any other resources as available. If a diagnosis or problem list is used, only diagnoses confirmed by the physician or nurse, non-physician practitioner should be entered. And although open communication regarding diagnostic information between the physician and other members of the IDT is important, it is essential that diagnoses communicated verbally also be documented in the medical record by the physician. Diagnostic information, including past history obtained from family members and close contacts, must also be documented in the medical record by the physician to ensure validity and follow-up. So if you're not sure that the resident does actually have a past history of something that needs to be addressed at this point in time, you need to communicate with the physician so that they can confirm or deny that that is a valid active diagnosis that needs to be followed up with and care planned. The second step is to determine whether diagnoses are active. So let me back up just a second. Okay, so first you identify diagnoses, and then you determine whether they're active. Because, you know, a resident may have had a peptic ulcer years ago, but it's resolved now. So that would not be an active diagnosis. So active diagnoses that have a direct relationship to the resident's current functional, cognitive, or mood or behavioral status, medical treatments, nursing monitoring, or risk of death during the 7-day look-back period. That's the definition of an active diagnosis. So you can, in the manual, you can read all about that, read the examples so that you get it, you know, clear in your mind what is and what isn't an active diagnosis. Do not include conditions that have been resolved, do not affect the resident's current status, or do not drive the resident's plan of care during the 7-day look-back period, as these would be considered inactive diagnoses. This slide just shows a continuation of the list from which you can code additional active diagnoses. The last part of section I, active diagnoses, includes fields into which you can enter additional diagnoses not previously listed elsewhere. One of the respondents to the poll we sent out asked, can ranking diagnoses be rearranged to reflect the resident's current issues that are being treated? Without asking for clarification, I would have to say no. But when you get to this section right here, if there are still active diagnoses that have not yet been listed, you could list them here in what you might consider a ranked order, right? Put the most pressing one as number A, and B would be the next pressing one, and so on and so forth. But the main item that captures that information was actually back at I-20, where you selected from the, was it 13 or 14 categories. Hopefully that made sense. All right, just a reminder that look back periods are 7 days unless another time frame is indicated. And now I will take questions about the information that I just covered. Hey, Chris.
Yes, Carol.
Are there, I see a lot of stuff in the chat, but it's basically about people.
Can anybody, can you type your questions into chat if you don't have the ability to use the microphone?
Well, we could unmute them.
There you go.
Or raise your hand if you have a question. Robin. You should be unmuted, Robin. Are you unmuted on your end?
Robin, are you able to type your question in the chat? We had the chat access open earlier. Can you unlock that, Carol?
I thought I did. Let me see. Oh, okay. I see Robin's question in the chat now.
Okay.
She asked if I can go over what is considered wandering. Excuse me. Wandering is walking around aimlessly, like nothing to do, no place to go, just, a lot of times residents will, excuse me, because of their mental status, they might not necessarily be they might not be able to interact with people, like have a conversation or whatever. And so they're just wandering around aimlessly, looking for something to get into trouble. I would think I would, like they're just wandering around looking for something to do. And basically redirection is the best way to handle that. Does that answer your question? What I would suggest is you look in the manual, because the manual at over 1,300 pages long does really get into the details of what wandering is. I mean, the information I presented was directly from the manual, but I didn't say everything that's in the manual. So please refer to the manual for further definition of what they consider to be wandering. And let me know if you have a more specific question that I can answer, Robin.
Carol, I see another question from Gail Birch.
Yes. Gail is asking about anxiety. If we are actively monitoring anxiety behaviors and they have PRN medications for anxiety, then is anxiety still active? I would say yes, because you're treating it, right? You're treating the anxiety with the PRN anxiety meds. So yes, it would be active. Well, if they didn't exhibit anxiety symptoms in the last 7 days, were they on the medications or they just didn't experience any anxiety during the last 7 days? That's what you need to be able to determine. I hope that makes sense. Again, the manual explains everything so much better than I can. It's just a matter of reading it and understanding it. And, I don't know if you all know this. I think most of you do. As the REI coordinator, that is my job. I'm here to answer your questions and provide support. So if you ever have a question about how to code something, after reading the manual and trying to figure out on your own, if you still don't understand it or need some guidance, you may contact me. And my contact information is on the next screen as well as in your handout. So, are there any other questions? All right. Thank you. Excuse me. Okay. Good timing. My voice has just gone out. Thank you very much for your attention. And now we will take care of a few technicalities so Chris can present his information. So if you give us just a few moments to make the necessary adjustments, we appreciate it. I'm going to stop sharing. Take it away, Chris.
Just a moment. Okay, can everybody see my screen?
I can see it. So I think they can. Looks good.
Okay, everybody can see that? Good. I think I'm on. We got somebody
I
else
can see
coming
it.
in.
Yeah, I can see it. Yep.
All
I'll
right,
take care
welcome
of-
everyone. My name is Christopher Cristiano, and I am the State Case Mix Coordinator with Nevada Medicaid. As you may know, Nevada Medicaid does an annual case mix review of our facilities here in Nevada. Nevada Medicaid has a team of both review nurses in the north and the south that review our facilities for coding accuracy. And I'd like to take a moment to thank you all for taking time out of your day to attend this presentation. Also to my co-presenter, Carol Eastberg, for her assistance with this. This has been quite the technological challenge for both of us. And as you have seen, we have some difficulty with using the Teams presentation. Typically, these presentations were done in person before, so as Carol said, this is the first time we've done this. So this presentation will be an upcoming overview of the changes to the Nevada case mix review process that many of you, I think, are at least somewhat aware of and familiar with. Granted that we haven't conducted reviews since the start of the public health emergency at this time. And a little disclaimer about the changes that I'm going to be presenting in this presentation. And that's the information that I'm providing is all that we know at this point. And we are working with Myers and Stafford and some other agencies to determine how we go forward at this point. We also have a stakeholder work group, which many of you are familiar with, that we have been conducting since, I believe, January now, that's discussing the upcoming changes to PDPM. Okay. Our two main goals with this program, the case mix review program that is at this point, are to fully transition to PDPM payment model and also a remote review process. And I will ask at the end of the presentation if you have questions that I am not able to answer at this time or that I am not sure of the answer, please allow me 1 week to obtain the correct answer and I will respond back in an email. All right. And with that said, let's get this presentation started. So our agenda is what you see there. And I found a saying that I liked, and I thought I would like to mention that in this review, that that is that change is hard, it is messy in the middle, and gorgeous at the end. So being a part of this process for over 1.5 years now, I am eagerly waiting that gorgeous part of this, needless to say. It's been a very complicated and seems to be getting better. So look forward to working with you all as MDS coordinators, nurses at your facilities, and with the team here at Nevada Medicaid and getting this process going. Okay. So our PDPM transition, Nevada Medication will transition to RUG-3 from the RUG-3 payment model to the PDPM model on July 1st, 2024. As I said, stakeholder meetings are currently being held. There's a lot of things involved with PDPM that as we've gone forward with this process, the stakeholders, your agencies, your providers that we work with are debating with us at this time. Some things we do know is that Section G will not be reviewed in our reviews. Section GG will be the focus of the reviews coming up, okay? And we'll go over that more thoroughly later on in the presentation. Items in Section GG, as many of you know, hopefully by this point, are obtained from the nursing function score in Section GG. And as I said, it's still being discussed if we will include those other sections that are included in PDPM, the NTAs, the PTs, the OTs, and the SLPs, okay? So our review start date, that is still being discussed, and depending upon how things move along, we have anticipating starting reviews as early as 10/1/23. That is not set in stone at this point. As I said, there's many things we need to determine before we start this process again. Part of the issue is having enough information to review, and what information we would review only having partial PDPM data starting 10/1, okay? Part of our review process in the past that we have discussed as well is changing it from a point in time, which is the current method, and that's a much simpler method, but it doesn't consider all the assessments for a given quarter, okay? Reviews will still be annual, and review notification process will be similar to what it's been in the past. So those of you who've worked with Nevada Medicaid, typically we send out a notification, I believe a week before the review process, and let you know that we will be coming in and reviewing the process, reviewing your facility, that is, okay? As those updates become available for you, those who are not familiar with our MDS PDPM email inbox, those updates will be sent out through that mailbox. If you do not have access to that, you'll have a link at the end of this presentation. I invite you to send me an email and I will add you to our nursing facility list, okay? And as well as any questions that you have concerning MDS or PDPM, please send those to that inbox. So a little comparison of the RUG-3 model that we used before versus PDPM. Part of the transition and the reason for it is that according to CMS, this reduces administrative burden to providers and improves targeting resources to our patients, which is what is important. It also improves payment accuracy and appropriateness, and it really focuses on the patient rather than the volume of services that are provided. In PDPM, scores are calculated through case mix group scores, meaning that like the minutes are no longer the driving force for payments, which in RUG-3 and RUG-4, especially RUG-4 from my understanding, which we never used, was part of the issue with that system. So as I said, it improves accuracy and appropriateness of the review process of what we're reviewing. So hopefully this will be a much better system than the RUG-3 for us and as well for you. Some other notes here, reverse scoring methodology. Under section G, an increasing score meant increasing dependence. A lot of you have heard these things before. And under section GG, increasing score means increasing independence. So there's really a nonlinear relationship to payment, okay? Under RUG-4 and RUG-3, increasing dependence within a given RUG category usually translated to a higher payment for our providers. And under PDPM, there is not a direct relationship between this. So these are sections we'll be reviewing for section GG. There will be other components, of course, to the MDS review for Medicaid, but I just wanted and only had time to go over section GG. And a little of this may possibly change. I know I've read that oral hygiene can be included in some of those things, but according to the direction I've received at this point, these components are what we're going to be including. And remember that if you don't know, the look back period for section GG is 3 days for the ARD and 2 previous calendar days. So eating, toilet hygiene, as we can see here, sit to lying, lying to sitting, side of the bed, sit to stand, chair to bed, chair transfers, and toilet transfers are those components we're going to be looking at. Okay. Our decision tree. You can find this in the MDS manual. I encourage everyone to look at this, utilize this when you're looking at sections of the coding for GG. It's called the 6-point rating scale, okay? And includes the following types of assistance. We have setup, cleanup, touching assistance, verbal cueing, lifting assistance, helper assistance is required score according to the amount of assistance provided, okay? We also have 4 other activity not attempted codes, and you can see them up here. Code 07, the resident refused. Code 09, not applicable if the activity was not attempted. The resident did not perform this activity prior to the current illness, okay? And again, you can find this information in the MDS manual. This is all pulled from there and other resources, okay? So on code 10, examples would be lacking patient equipment and weather concerns. I made a little note of that. It says not attempted due to environmental limitations. So those would be some things that you would need to see in the document if you or in the documentation if you coded that, okay? And those are the things that we look for on reviews, accurate documentation that reflects why those things were coded, okay? So usual performance in GG. This is one that's stressed repeatedly throughout section GG. And when you code any items in GG, it asks for that usual performance. Is this the usual performance of the resident? Okay. So you need to be sure that these codes reflect and accurately describe what sources of information were obtained and the methods that were used to determine the resident's usual performance. As we do our reviews, we'll be looking for that documentation again. And you may need to use the entire assessment period to accurately describe the resident's usual performance. Couple steps for assessment here. And again, this is pulled from the MDS. The documentation should accurately reflect where the information for the assessment was received from what sources. And in GG, it talks about using multiple sources for that assessment, and that would be the medical record documentation, the patient themselves, the patient's family are all applicable sources for this documentation. Okay. Some notes on this here, as you see in number 3 there, when helper assistance is required, consider only facility staff, okay? And that's another item that's stressed repeatedly throughout section GG, facility staff. So that means facility staff that are hired directly by the facility. That would not be external staff such as hospice, CNAs, nursing students. So when you're documenting, make sure that you identify that it was facility staff, okay? And then also with or without assisted devices. That's another important piece of documentation that you need to make sure that you're putting into those notes, okay? Eating, GG0130A. So here's some things that are important about eating. And this may be one of the items that may be worth reviewing details of documentation in the MDS thoroughly, I would say. And this will also probably most likely be added to our Nevada documentation guidelines. I do anticipate that there may be some complications with this coding of this item accurately in the documentation, okay? As you see here, I've highlighted gave you the definition, and it says eating involves bringing food and liquids to the mouth and swallowing food. The administration of tube feedings and parenteral nutrition is not considered when coding this item. So our next slide here offers a little guidance for situations in which a resident receives tube feedings or parenteral nutrition. So just the big thing to remember here is that this is not considered when coding eating, okay? TPN, parenteral nutrition. So let's look at what I've highlighted here. On the first example here, if the resident does not eat or drink by mouth and relies solely on nutrition and liquids through the tube feedings or total parenteral nutrition, TPN, because of a new recent onset medical condition, GG0130A, is coded as 88, not attempted due to medical condition and safety concerns. And as you can see in the 2 examples below, again, important to read through these examples, look at this very thoroughly because this is where I anticipate seeing some issues possibly. Toileting hygiene. A couple tips for toileting hygiene. And again, this is based on the resident's need for assistance, okay? Managing clothing, and perennial cleansing, things like that, okay? Perennial, I'm sorry. I said it, Carol, perennial. We were joking before the presentation, as we were practicing for this yesterday, I said perennial, and we were saying annuals, perennials, oh my gosh. I can't believe I just said that. Sorry, folks. Okay, so we assess the resident's mobility performance, and the resident should be allowed to perform activities independently as possible, okay? And as we read through these, I want you to think about how you would document these items to reflect that in a note that we would be able to easily see. And that's what we look for as MDS reviewers. We look for information in the notes that's easily accessible, that identifies and compares to what we are reviewing, okay? And what the MDS manual says, as well as the Nevada documentation guidelines. We're going to talk later about some tips on how to accurately put that information into a note so that, you know, it's easier for you. We don't have to look through 20 records to find that information. And that's the goal of our new process, is to actually make these reviews much shorter. Okay. Number 2 there says, for the purposes of completing section GG, we mentioned this earlier, helper is defined as facility staff who are direct employees. Okay. So again, remember, not those people who are not outside the facility. Okay. So just for an example, this doesn't include individuals hired or compensated or not by the individuals outside management. And as I said, hospice staff, CNA, nursing students, etc. So if if helper assistance is required in these cases, and it's because of a resident's performance is unsafe or poor quality, only consider those facility staff when you're coding or documenting, okay? All right, I don't think I have much more to say about that. And again, with all these items, usual performance is what they stress throughout GG, okay? Sit to line, usual performance. So that is what we're looking for, and that's what you need to be documenting for our reviews. Some notes here on this one I wanted you guys to all notice was that do not record the staff's assessment of the resident's potential capability to perform the activity. When coding the resident's usual performance, highlighted effort refers to the type and amount of assistance a helper provides. So note that, okay? The effort refers to the type and amount of assistance a helper provides in order for the activity to be completed. And again, go back to that 6 points rating scale that we had earlier, use that decision tree. Typically, I know when we had when we did the rule of 3 and stuff, we had some really great little handouts that you could just carry with you, little cardboard handouts. I think they were provided by ANAC or something. And as we move forward with this process, I'll look for those resources to get those sent out to our providers and possibly use it as just a little assistance tool. Okay. Lying to sitting on bed, GG0170C1. Okay. This is the resident's ability to perform each of the tasks within this activity. And again, it's how much support the resident requires to complete those tasks. Again, it's important to see the examples in the MDS manual and wherever else you can find those resources, okay, for accurate coding. We're going to talk later in the presentation about some tips we have for, kind of checking yourself before we do the review to see if, you're coding these things accurately and documenting accurately, all right? Nothing of particular note on this slide. I'll have you all review that as you look through your slides there. And then GG070 170D1 sit to stand. So coding tip for this was, if a sit to stand assist lift is used and 2 helpers are needed to assist with the sit to stand lift, then code 01 as dependent. Okay. GG017E1, chair bed to transfer. As you can see, this begins with the sitting in the chair or the wheelchair. And remember, with these items, as you're coding them, assistive devices are included in this. So that's also another important piece of documentation that you need to include in your note, whether assistive device was used or not, okay? So you can see on the second bullet point there, it says 2 helpers are needed to assist with the mechanical lift transfer, then code 01 dependent, even if the resident with any part or the chair bed to transfer. Okay. And then toilet transfer, all I had for this was follow the decision tree as in the previous examples. And always remember to code usual performance. As I said, use that entire assessment period when you're making your note or coding for this, so that we can see that you had looked at that. So here we go. Tips for success. Understand the importance of functional improvement and how to best facilitate resident progress. Review and adapt current GG coding practices to ensure a collaborative approach to coding determination. Review that 6-point rating scale and activity not attempted codes. And establish a documentation protocol to support GG coding decisions. So that means within your own facility and MDS coordinators, come up with something on your own, and it's good just to write these things out. Type them out for yourself to have little notes to look at as you're doing this, okay? Or making your notes in your progress notes that we look at. And then practice coding in a variety of scenarios, okay? And then, of course, you can review, audit yourself for accuracy and ongoing basis, okay? All right, the Nevada Supportive Documentation Guidelines. Some of you may be familiar with these, some of you may not. I'm not sure, since the public health emergency and being that we haven't been involved with the facilities directly as the reviewers, that this has been something that's been brought to all of your attentions. It's an important document, and it is a document that we use that is above and beyond what is required federally, okay? I have some examples I'm going to show you in a few slides here of what the document looks like and where you can find it. Oh, actually, on this slide right here, if you go to LTSS Nursing, click on there, and in the search bar, if you type in Nevada Supportive Documentation Guidelines, you will get the most updated one we have at this time, okay? A new version will be coming out in the near future. I don't have a date for that, but hopefully, obviously before we start our reviews, if that's the case, but hopefully no later than by the end of the year, we will have something new that will include the GG sections that we'll be using for our reviews, as well as any other items that we conclude that will be adding to those. So look for those. I will also send those out through the MDS PDPM mailbox. So anybody that's on my list as a nursing facility MDS coordinator, or anybody else who may need that document, please send me an email and make sure you're on that list, and we will get that sent out to you as soon as they become available. Okay. But do remember, as I've highlighted here, these are Nevada specific requirements. So when we go in and do a review, if these requirements are not met, then of course we hold you accountable for that. Okay, so you won't do as well in your review. Okay, do take the time to look at these, even this older version right now, so that you become familiar with that. Okay. This is just part of the footnotes, or actually, I believe the top portion of the Nevada documentation guidelines, and you guys can read through that. I can't actually see it on my thing here, so I'll give you a moment to look at that if you haven't seen that documentation before. Right? And I apologize if you can't. I think, Carol, can you see that clearly? It's so small on my screen, I can't.
Well, if you look really close, if I look really closely, I can see it.
Well, I'm wondering if you're seeing, like, I'm not seeing a full screen view of it. So I know when it's in full screen view, you can see it fine. So
Oh,
if you're
yeah.
having trouble with that, just go to full screen view. Okay. And what that talks about on that one that we're on there, whoops, I skipped forward here, is the review procedures. Okay. And it says that supporting documentation related to the MDS case mix documentation review. Any corrections made, including but not limited to the ADLs, ADL grid, must have an associated note of explanation per correction within the observation period. So that's most likely going to apply to any new sections we add in GG, okay, that type of requirement, okay. B says a quarterly, annual, or summary note will not substitute for documentation which is date specific for the observation period. Same thing with our PDPM process, most likely, okay. C says improper, ineligible, illegible corrections will not be accepted for MDS case mix review documentation, and that will be the same. All documentation, including any corrections, must be part of the original legal medical record. That will be another requirement. Any and all MDS coding and interpretation questions shall be referred to the local state RIA coordinator. And I guess we're kind of giving Carol all the work there, but you can reach out to me. If I cannot answer the question, I typically reach out to Carol. I look at all my resources, just as she said in her presentation. We will get you an answer, okay? And F, of course, says that any late entry documentation more than 72 hours from the ARD will not be accepted. Those items will not change, most likely, okay? There may actually be more added. It may be changed a little bit. When we get that new document, we'll let you know, okay? So this next page here is just an example I wanted to point out. And one of the items that frequently comes up in the reviews in the past in facilities was this AEB requirement that you see there, okay, and frequency. When we looked at notes, we often didn't have the evidence that we need that item had occurred, or that documentation had occurred, or that whatever that code we were looking at had occurred. And one of the easy ways I learned when I was doing reviews was just to put that in there at the end of your note. As you all know, when you go to nursing school, you always have to have as evidence by, right? So we're requiring that in quite a few items in our Nevada documentation guidelines. And I do anticipate in the future, as we add GG, we will have that as evidence by requirement mentioned a few times, okay? As well as frequency. If that's a necessary thing that we're reviewing, please put that in your notes. That helps us a lot. You know, oftentimes what we'd have to do is we'd have to look through several different documents and note to find out if that actually occurred. That takes up time for you as reviewers or as MDS nurses, as well as us as reviewers, okay? All right. So this next one is a footnote, I believe. Still having trouble seeing this. Let me go to my other thing here. And this was about the signature date for Z0400. The interview items, BIMS and PHQ9 must be conducted during the observation period stated in the RIA manual, and a signature date entered at Z0400 must be prior to or on the ARD, okay? And unless that changes, we get direction or anything, that's going to be the same, okay? The signature date for these items, interview items at Z04 must match the date of the interview was actually conducted in the medical records. If these dates do not match, facility will not receive credits for these interview items due to conflicting documentation, okay? C says in rare situations that the interview items were collected and completed by two people or by the same person, but on different dates, meaning half the interview questions were conducted on the next day, each person must enter the signature date at Z0400 and indicate specific interview questions conducted, okay? So as I've encouraged, look at this document thoroughly, make sure that you know what's required by Nevada and what we'll be looking for in our reviews. And as I said, even though this doesn't have GG in it is still valid and we will be using it, okay? All right, that's it. I have, of course, myself as a resource as well as Carol. And unfortunately, one thing I forgot to put in this presentation is Medicaid now has a listserv site for nursing facilities. and you can go to the Nevada Medicaid long-term services and look that up. I will send out a link via the MDS PDPM mailbox, which I believe I already did. So most of you, if you're on my emails, you should have received that, okay? But I encourage you to sign up for that as well so that you get any other notifications, not just related to MDS, but also to long-term services and whatnot, okay? All right, with that said, that is the end of my presentation. So let me get over to the chat box here and see what we have.
Do you see the question regarding section G?
Yes, regarding
Okay.
section GG, where the RAI manual states that the assessment must be completed by a qualified professional. Does Nevada have any clarification on the definition of a qualified professional? That's a great question. And you know, I was just looking at this information yesterday. I wish I would have put it in the presentation here. And does the RAI manual have that in there? Does it outline what they say? It tells you to go to your state requirements, I believe, right? So I'm gonna get that
Refer to
answer.
Carol.
No. I actually just saw this yesterday. I was looking through
Oh, okay.
information. I saw this. So I will send that out via the MDS mailbox. And Karen, I'm gonna specifically put you on there. Karen, are you an MDS coordinator? And which facility are you with? If you could type that in the chat box if you're not able
I can
to.
tell you, Chris, I have that information. And actually, yeah, it's on the email list that I shared with you.
Okay, so I'll get that sent out to you probably today. I just was looking at it yesterday, and I want to make sure I give the full answer before I answer that. Okay? The right answer.
Perfect.
Is that it?
I don't know, is it? Any other questions?
One thing I would like to add, as I said, we are having stakeholder meetings right now, and we've already had quite a few of those, I think 4 now at this point. If you or if you think anybody else at your facilities need to be involved in those meetings, and they are higher level meetings, they don't necessarily relate to MDS coordinator so much, but more so the actual changes with payments and stuff like that that are occurring. And so that's being debated in these meetings. But if you feel like you might benefit from attending those meetings, please send me an email as well, and you can still sign up for those.
Right.
All right.
Bernard Gordon has asked if you can expound on the pain assessment, the J section.
I
I didn't-
can, but not again in this
Off the cuff. Yeah.
off the cuff, no. So that'll be another one, and I'll send that out to you, Bernard. Pain assessment. Where's that question, Carol? I'm not seeing that. Let's see.
Let's see. Well, on my screen, it's the
Okay, I
second
see it.
from the
J
bottom.
section, section
Yeah.
J. Yeah.
Okay, are there any other questions about material that was covered today in either my presentation? Maybe you thought of something. Paula has a question. I don't know how to. let's see. Yeah, I think the answers should go out to everyone, Chris.
Okay, so we'll just
So
do that.
yep.
The 2 questions I have, and I apologize for not being able to answer those. Like I said at the beginning of the presentation, I want to make sure I'm fairly new to this position, about 1.5 years now, and my experience with reviews was prior to the public health emergency. It was only a few years I was doing it, so I want to make sure that I give you the correct answers for your questions. Okay. All right.
Well, I guess it's time for everybody's favorite portion of the training, and that would be the post-test and evaluation, which I need to send to everybody via email. So give me just a moment, please. I've got it already set up and ready to go. I may need to add a few more people to the list. I'm only showing 62. Chris, you have any clean jokes you can tell us while I'm doing this? Can't hear you. I think you're on mute. You're going really slow and I can't hear you.
Sorry, I had my mic off. I do have a clean joke, and I actually won some money at a race that we had one time where my brother races cars. And you
Cool.
can tell this to your kids, and it's. I don't want you to go out and make $1 million off it, though, folks. Okay, so the joke is, what did the right butt cheek say to the left butt cheek? Carol, anybody? You got any answers in the chat?
I think I'm gonna crack.
Can you move over? There's barely a crack between us.
Okay, I can't answer your jokes and do what I'm supposed to be doing right now at the same time, so give me a moment. I gotta figure out who's not on the list already. Okay, here we go. I'm gonna send the post test to you as well, Chris, just so you can see what it looks like and you can go over the answers for your portion of it, okay?
Thank you. And you're going to be sending this out in a link, I think, is what you're doing,
No,
right?
no, it's an attached document to an email.
Oh, okay.
If the administrator at Highland Village of Fallon could please put your email address in the chat box, because the name that you registered with is telling me it's not going to be able to send it to you. Oh, I think I see what's wrong. There's no .com at the end of it. Okay, so I just sent the email. Please give it a moment to arrive. And while we're waiting for it, I'll just tell you what the email says so you don't have to read it when you get it. Excuse me. Once you've answered the questions, all of the questions, I think there's 12 questions, true or false questions, click on whichever answer and then save it. Because after everyone is finished, just like we've always done in the past, we're going to go over the answers. And then I need for you all to return your completed post-test and evaluation to me by 5/22. That's a week from yesterday. Oh, no, that's Monday, the 22nd. So the mandatory report that I have to submit to CMS will be accurate. I need to collect the data that was in the registration form in order to be able to submit that data to CMS. So I appreciate your cooperation with that. And can anybody please tell me if they received the email yet with the post-test? I see Angelita's asking if the presentation is being recorded. Yes, it is, along with captions even. Yay, I got a few people that said they got it. If you're with Ensign Services, there seems to be an issue. Where did I see that? Who didn't get it? Did not receive it, Sarah. Sarah, you're not on the list of people who registered. All right, well, for those of you who did not receive the handouts, I apologize. As I mentioned at the beginning of this training today, this is a first for me doing a Teams meeting where I'm on the presenting end. So just keep in mind that whatever information you put into the registration form, that's the information that's going to come to me. So if there's a misspelling in the email or whatever, you're not going to get it. So just double check and make sure that everything is spelled correctly. And next time I will have a deadline for registering so that people aren't registering 5 minutes before it. And then I've got to scramble to try to get them the handouts, which is what I did this morning. So let's see. It looks like most people did receive the post-test. Fathila.
And Carol, I just, if you don't receive the documents, just send an email to myself or Carol and we will get those to you, okay?
Princess, I sent you the I hate it when the thing moves up when I'm trying to read it. Princess, I did send you the handouts and I also sent you the post-test. Can you confirm that you received either one after I resent them or sent them? If any of you are uber experienced at setting up and presenting Teams meetings, I would love to hear your tips and tricks for how to make it go smoothly, because the instruction manuals that are available are just very technical. I just need somebody to tell me, well, if you want to do this, you press this button and whatnot. So that would be very much appreciated. Okay, Fafila and Princess, I'm resending the post-test. Anybody else that needs it, please speak now or forever hold your peace. 200 received. Okay. And Eric, did you register? Yes, Brenda, save your test and then email it back to me. And that way I can prepare your certificate and send it to you. Miss Carol. Marilyn, these are actually the brown bag meetings. We're just, we're moving that whole thing into the future. So we're not calling them brown bags anymore, because the brown bag name came up because people would bring their own refreshments when we were meeting in person, but we're no longer meeting in person. So I don't know. So we've updated it. Hope that helps. Okay, you guys, thanks for your patience. Just so you know, this is scheduled to go until 12 noon. So bear with us while I send out these post tests. Jermaine. Can you hear the Jeopardy music playing in your head? I don't know what's going on. I did send the handouts to the DON at Highland Manor of Mesquite. No, I think it was Elko. Dathala Jamora, I have your email address as dathalamateo11@gmail.com. Is that the correct email to use?
Carol, can we let the ones who have received the handouts and go on the meeting? Do you think that's okay now at this point?
What do you mean go?
To sign off the meeting if they've got the
No,
handouts and the test now?
no, because we want to go over the answers.
Oh, okay.
Remember? Yeah.
Sorry.
And plus, I'm still sending them to the people who didn't receive the tests. Let's see. Sarah, I've got yours. So Sarah, you didn't receive the handouts or the post test? Okay. Just resent it to a handful of people. Barbara, what's your last name, please? I gotta tell you, for some reason, it does take a minute. Actually, more than a minute, obviously, for these to get through. So patience, everybody. Okay, Sarah got the one I just sent, as did everybody else who was on that particular email. But Barbara, I don't see your name anywhere. Oh, wait, let me go back to the actual registration. Come on in, Boleyn. Guess I need to refresh this, but I don't know how, because This morning, the last person that I show as having registered was at 8:55 a.m. So there's no Barbara on the registration list. I'll tell you what, for those people, Barbara, can you please put your full name and your email in the chat box so that I can send you the handouts and the post test? Did you use a different name to register maybe? Barbara Harrington, okay. And I need your email, please. Thank you. I don't know who. Somebody has their hand up. Oh, Paula. Yes. Let me unmute you. Paula, are you muted on your end? Oh, okay, no worries. Okay, so I believe I have sent at least the post test to everybody now. Wish there was an easier way to get a consensus on who's got what. Like I said, if you have any tips or tricks on how to do this, we're definitely open to them. Daneo, did you finally get the handouts and the post test? Hey, Chris.
Yes, Carol.
Do you know how to unmute everybody at the same time?
I will look into that right now. Just a moment.
Okay, thanks. Paula, the document was a combination of the post-test and the eval. So it was like 2 pages. The first page is the test, and then the second page is the eval. I need both documents back. Okay, perfect. Thank you. Radine Sineo, are you at Silver Ridge now, or what's the email? I've got 2 different emails for you. I'll just send them to both. Okay, Silver Ridge, thank you. Okay, so who else has not received either the handouts or the post-test? I'm just going to send both. So only respond in the chat box, please, if you still need either one of the documents that we sent out earlier. Jermaine, okay, gotcha. Okay, Hope, I see. Thank you. Well, I haven't sent yours yet, Eric. Give me just a moment. I'm trying to include as many people in this email as I can, so I don't have to resend it. Hope. Hour. Jessica Jane. Gotcha. Jessica Jane. Okay, anybody else still need either the handouts or the post-test or both? Like I said, okay, Rosa. Rosa, that looks like an unfamiliar name. Did you register? What's your email, hun? Oh, Rosie, yeah. Shoot. You should have gotten that, Rosa. All right, sending it again. Oh, I'm looking at two Rosas now. Rosa Lopez, you didn't get them? Okay, thank you. Resending. Okay. I'm sending out the latest batch right now. 3 documents, both sets of handouts, and the post-test / eval. Does anybody know how to make holy water? Put your answer in the chat box if you know how to make holy water. You're on the right track, Aaron. How does the priest make holy water? Yes and no. Good one, Paula. No, holy water is made when you boil the hell out of it. Bump.